Recently, KDIGO has come up with an update for 2026 in managing anemia in CKD patients. We might think that we are already treating anemia since long time in CKD patients using iron supplements or some erythropoietin stimulating agents, even blood transfusions and all. Why is it required to get update? The point here is there are some newer molecules as well as evidence from clinical trials along with proper recommendations for optimal targeted therapies. That's why it is important to have this update. So we will discuss it today. First of all, we know that anemia is a common complication of CKD. Commonly we will be seeing, and sometimes even when we are suspecting chronic kidney disease, we will check for the associated feature of anemia. And presence of anemia in CKD will increase the burden of morbidity, mortality, and also it will reduce the quality of life. We had previous guidelines, but as I mentioned, there are some newer strategies and some important clinical trials like pivotal trial. Also, introduction of some newer agents which we will be discussing in detail, and proper guidelines for the optimal treatment targets. So these are few things compared to the older guidelines which we will be discussing in detail. Overall, 2026 guideline will provide a comprehensive evidence-based update. Okay, now what we will do is from this 2026 guideline, we will navigate this particular section in 4 important chapters. First one will be mainly on the diagnosis and evaluation of anemia in CKD. Second one will be regarding iron management. Third one is about the newer agents like erythropoiesis stimulating agents and hypoxia inducible factor proryl hydroxylase inhibitors, which we will be discussing in chapter 3 of this particular section, and finally about the blood transfusions. Coming to the chapter 1, that is diagnosis and evaluation of anemia in CKD. We all know that according to WHO, in adults commonly we consider hemoglobin of less than 13 in males and less than 12 in females as anemia. This will apply to CKD patients as well. And as the stage of CKD increases, chances of getting anemia will be increased. Commonly, from stage 3 of CKD, we will be able to find anemia in majority of the patients. So remember stage 3. Now what will be the reason, that is pathophysiology of anemia in CKD? Because of chronic kidney disease, there will be relative erythropoietin deficiency. This might be the factor, and dysregulated iron homeostasis. So as CKD is a chronic disorder, there might be increased hepcidin levels in the body leading to anemia, and there will be shortened red blood cell survival in some individuals because of blood loss, especially those who are undergoing hemodialysis, and as I mentioned, due to systemic inflammation. So these are some pathophysiological reasons for anemia in CKD. Now, if the individual is having anemia, what will be the outcomes? We know that it will increase mortality, morbidity, and the events of major adverse cardiovascular things like MI, stroke, or uncontrolled hypertension. All things will be increased. So definitely there will be increased risk of kidney failure progression. There might be left ventricular hypertrophy, lower quality of life and cognitive impairments, and there will be increased hospitalizations. So these are some effects of anemia. Now comes an important slide for the evaluation and a step-by-step diagnostic pathway for anemia. See, what we have to do whenever we have the case of chronic kidney disease, from stage 1 to stage 5, or if the patient is on dialysis, hemodialysis, or if the patient of kidney transplant recipient. So all these individuals needs screening with complete blood count, reticulocytes, ferritin, and transferrin saturation, all these things. So first of all, we will get CBC done. So as you can see on the right side here, CKD stage 3, we have to screen them every year to find out the incidence of anemia immediately. If the individual is in stage 4, do it twice a year. Or if stage 5 or on dialysis, we have to be repeating CBC every 3 months so that we will be able to identify anemia early, right? So what is that? At one particular screening test, the individual will have hemoglobin of less than 13 if the patient is male and less than 12 if the patient is a female. So this confirms anemia. Then what we have to do? We have to send for iron profile. In that, we have to assess two important parameters. One is ferritin, one more is transferrin saturation. So based on these two, the further management will be guided. See, for example, these patients who are not yet on hemodialysis. So for them, remember few of the numbers. For example, in these individuals, if the ferritin level is less than 100 and transferrin saturation less than 40, or else if the ferritin level is less than 300 and transferrin saturation is less than 25%, then we have to consider iron therapy in these individuals. We are talking about those CKD cases who are not yet on hemodialysis. Suppose the individual is on hemodialysis, then you have to take some higher cutoffs like ferritin if it is less than even 500 and the transferrin saturation less than or equal to 30%, we have to consider them as iron deficient. So these are few numbers, don't get confused. First decide whether the individual is on dialysis or not. So based on that, we will utilize these two parameters, right? From these numbers, what we can get easily is we have to be little aggressive in treating or taking steps when the individual is on hemodialysis. If not on dialysis, we can wait till the ferritin level falls below 300. But here comes a confusion in the number which I have mentioned. How can transferrin saturation levels be near 40 when the ferritin levels are less than 100, right? So here you have to know few of the reasons. For example, ferritin is nothing but our bodily iron stores. So stores will get depleted first in the early stages before transferrin saturation falls. This might be one reason. Second one, if the individual is being supplemented with iron, IV, then there might be sudden spike in the level of transferrin saturation. So that might be one more reason. Otherwise, as CKD is one of the chronic inflammatory condition, so that the TIBC, total iron binding capacity, which will be decided by the level of transferrin produced by liver, which will be obviously lesser in case of inflammatory conditions. So when TIBC itself is low, whatever the little iron is present, it will bind to the transferrin, falsely impacting a higher transferrin saturation. So these are some reasons where we can see a near normal or higher transferrin saturation with lower iron stores in the body with low ferritin levels. Okay, now you have confirmed anemia, you have sent for iron status, we have seen ferritin levels and transferrin saturations. So based on this, we will be giving iron supplements. Next is one more important point. We have to always check for whether the iron deficiency is too severe. That is nothing but ferritin level of less than 45, or if peripheral smear is already showing microcytic anemia. This will indicate severe iron deficiency. So if this is the case, we have to look for other causes of blood loss. For example, gastrointestinal, genitourinary or gynec reasons for blood loss leading to such severe iron deficiency, because in CKD, whatever might be the mechanisms, it will not lead to such severe iron deficiency. And as discussed in detail, if it is not that severe but still iron status is suggesting lower bodily iron stores and all, we have to consider iron treatment. If during this evaluation you find there will be anemia but iron status looks fine, in that case we will not be able to find out a clear cause. We need to work up further by sending B12 levels, folate evaluation, and liver function test, etc. So perform full anemia screening if it is not due to iron deficiency. Now once iron deficiency is confirmed, what we have to do next? In 2026 guideline, they have proposed some of the newer terminologies so that we will be able to understand the pathophysiology better. For example, the individual might fit into one of these two mechanisms. That is, there might be either systemic iron deficiency or iron restricted erythropoiesis. Previously, this systemic iron deficiency was called as absolute iron deficiency, whereas iron restricted erythropoiesis was nothing but functional kind of thing. This is, you can just compare for easier understanding with the diabetes. In type 1, there will be absolute deficiency, whereas in type 2, though insulin levels will be proper, there will be resistance to that. Just a similar kind of picture here as well. Now, to understand these two, we will just try to imagine a story of a home which has a dog inside, a dog, then it is being locked. Okay, so this home is there, they have kept a dog inside and a lock. Just for the easier comparison, I am saying. So in this picture, we can see that home is nothing but macrophage. So this is macrophage, and this dog is nothing but iron, and the lock is hepcidin. Okay, just compare it like this. So what happens when there is absolute deficiency of iron in the body? So overall our iron stores are low in the body, right? So naturally what happens? Hepcidin level will fall. So this lower hepcidin will allow the release of stored whatever available iron was there inside the macrophages will be released. So this will be happening. When we get lab profile, there will be decreased ferritin levels, like it will be severely depleted. For example, less than 100 we can see. And when you see transferrin saturation, it will be lesser because the iron, even though it is coming out, will be lesser in quantity binding to transferrin. So the saturation will be definitely low. This picture we can see when there is total absolute depletion of iron stores. On the other side, in iron restricted erythropoiesis, what happens here is there will be, you can see, adequate or higher iron stores inside the macrophage, but it is not able to come out of it. Why? Because it is locked. So this will happen in case of inflammation if it is associated in the body. So mainly due to inflammation. Inflammation is like a thief who is there in this home's surrounding. So when thief is there, everything will be locked. That is, hepcidin level will be high. If we get the lab profile, we might see overall body iron stores might look normal or even higher, like in the range of 100 to 200. But because of non-availability outside, the saturation of transferrin will be lower. So this will be one more situation. As mentioned in the evaluation flowchart, we might see two different manifestations. Hope you have understood the point. Overall here, if along with CKD, body is having inflammation, then hepcidin level will be raised because it is a positive acute phase reactant. So that raised hepcidin will block iron from coming out of the macrophages, as well as it will block the absorption of iron from intestine as well. So bilateral blockage will lead to fall in the transferrin saturation. But because of this locked in state of iron inside the macrophages, overall stores might appear as normal or higher. That is nothing but ferritin levels might be between 100 to 300. This is one situation. If there is only CKD with absolute deficiency of iron without any inflammation, in that case, hepcidin level will fall. That will lead to release of whatever the little iron available inside the macrophages to the main bloodstream for functional form of iron. So there will be total depletion reflected by low ferritin as well as lower transferrin saturation. Now once we have confirmed iron deficiency and probability of inflammation present or not. So all these things are done. Now how to treat this? The key recommendations for the patients who are on dialysis, hemodialysis, suggested thing is, as mentioned earlier, we have to be little bit aggressive, because even if the ferritin levels are less than 500 and transferrin saturation is near 30 or less than 30, we have to initiate iron therapy. So what will be the route of administration? It is suggested to use intravenous route rather than oral. And the dosing strategy, here remember, whenever you are giving iron, always try to follow proactive approach to maintain stable iron status. So what is that? It is nothing but from pivotal trial, it has seen that a proactive high dose IV iron therapy will be very, very helpful to lower the rate of composite outcomes like MI, strokes, hospitalization for heart failure, risk of death will be lower, and there will be fewer transfusions, even fewer requirement of ESA therapy, and there will not be any counterpart increase in the infection rates. So these are all the advantages of proactive iron therapy. What does that mean? In these individuals, every month minimum 400 mg of IV iron should be injected, unless the individual is having ferritin level of too high, that is more than 700, or if saturation of transferrin exceeds 40%. So till that level, see, remember, we have started when ferritin levels were less than 500 or transferrin saturation was less than 30. For example, this individual on hemodialysis had a ferritin level of around 400 or 300, like that. So this individual we have started on iron supplementation. So how we have to start? Every monthly minimum 400 mg of IV iron should be supplemented, and we will be keep on checking the status. As mentioned, we have to screen these hemodialysis individuals every 3 monthly. If we find ferritin levels of more than 700 or transferrin saturation of more than 40%, then only we have to withhold iron supplement. Otherwise, we have to keep on giving this maintenance dose. So this is called as proactive approach, which is found efficacious when compared to reactive strategy. That is, we will be giving IV iron whenever we find lab values of less than 500, then and there itself. And once we reach the target level, then we will be stopping. Again, when we recheck, if it is found to be low again, then only we will be giving. No maintenance monthly iron IV injection. So that is nothing but reactive strategy, which is not much helpful according to pivotal trial. What about those CKD patients who are not on hemodialysis? So in those cases, as mentioned, the threshold for initiation of treatment will be remaining same. Absolute deficiency like ferritin less than 100, even if the transferrin saturation is near 40%, or ferritin level less than 300 and saturation of less than 25%. In this case, we will be initiating. So what will be the route of administration? Here it depends. We have to take shared decisions. Both oral and IV iron therapy will be equally efficacious. But we have to know what are the advantages and disadvantages of each of these. For example, if we choose to supplement with oral iron, the effect will be slower, but it will be convenient and it is less expensive, but more frequent but less severe GI side effects will be seen with oral iron therapy, and potential adherence issues will be there. Whereas in IV therapy, it is a more rapid effect strategy and there will be assured administration, less frequent but potentially more severe side effects, as you might have seen hypersensitivity reactions with IV iron supplementation, and it is quite more expensive and it will require healthcare providers proper observation during the therapy. Some of the practical considerations for safe and effective iron administration. Remember, if the patient is not on dialysis, we can monitor every 3 monthly. If the patient is on hemodialysis, we have to be more frequently checking for hemoglobin and iron status. So every 1 to 3 months. Then upper limits we have to know. If the ferritin levels are more than 700 or saturation of transferrin crosses 40%, then we have to withhold the routine maintenance therapy. Otherwise, in case of infections, we can temporarily suspend iron therapy. And whenever we are giving IV iron, always monitor for hypersensitivity reactions. For example, there might be a mild reaction in the form of minor urticaria. So in that case, just withhold, give some steroids or antihistamines, then we can restart the thing again with even more careful observation. Suppose there is severe reaction in the form of stridor, hypotension, all these things, then we have to manage this anaphylactic shock with IV fluids, oxygen, adrenaline, and we have to avoid future use of IV iron in that severe hypersensitivity reactions. Coming to chapter 3, which is mainly focused upon the novel agents like erythropoiesis stimulating agents and hypoxia inducible factors. First thing is deciding when and how to initiate these therapies. See, whenever we think of these therapies, few points are very important. First thing is always correct the stores. For example, iron stores, B12, folate, these all should be supplemented properly. Then only try to stimulate for erythropoiesis. This is the first point. Then consider patient's factors, because these agents are having higher risk of ischemic events like MI, stroke, and there might be uncontrolled hypertension with these agents. Even the risk of cancer will be higher. So all these parameters should be checked, considered before initiating these agents. So once we have checked all these things, what will be the option for us? Remember, the first choice among these still remains ESAs, erythropoiesis stimulating agents. For example, erythropoietin alpha, darbepoetin, all these agents we can utilize rather than the newer molecule, that is hypoxia inducing factor. This PHI stands for proryl hydroxylase inhibitor. What are the key thresholds for initiating ESA therapy? Remember, if the patient is on dialysis, then we have to initiate ESA therapy when hemoglobin is in the range of 9 to 10, and in that case target for a hemoglobin of below 11.5. We should not go above this value, because above this there will not be any added extra benefits. Instead, it will increase the risk of multiple adverse cardiovascular events. That's why whenever you are treating with ESAs, keep this target of 11.5 and below. And what will be the dosing principle? Always try to administer the lowest possible dose. For example, we all might have seen erythropoietin injections, erythropoietin alpha. Usually it will come as 4000 international units, right? We will be giving through subcutaneous or IV route. So whenever you are using IV, try to use quite higher dosage. So this one we will be using, and often 3 times a week it will be given. And we will be checking for the target hemoglobin, that is nothing but below 11.5. So once we have started on this therapy, every 2 to 4 weeks we have to monitor the hemoglobin values, because after initiation of any dosage of ESA, once we repeat after 2 to 4 weeks, in that time period there should not be a rapid rise by more than 1 gram per deciliter in hemoglobin. So in that case, if such rapid rise if you see, then try to lower the dosage of erythropoietin, and whenever you reach hemoglobin of 11.5, then we have to stop the therapy. So these 2 points are very important. Start on low dose, monitor every 2 to 4 weeks. If there is rapid rise by more than 1 gram per deciliter, you have to lower the dosage. If you reach absolute value of 11.5 or higher, you have to stop the therapy. What about the newer agent, HIF, PHI? We know the full form now. Hypoxia inducible factor, proryl hydroxylase inhibitors. This is what, there is an enzyme in our body called as proryl hydroxylase, which will metabolize a factor called as HIF. So this HIF is very important. It will induce hypoxia and leads to natural stimulation of erythropoiesis, right? But this enzyme will break down this and always try to inhibit this process. So what we are doing, we are inhibiting this particular enzyme so that the HIF will remain for a longer period and it will lead to stimulation of natural erythropoiesis. See, ESA was like supplementing external erythropoietin, right? So what it will do when it reaches our body, it will try to stimulate bone marrow. In that way, it used to increase the hemoglobin levels. But here, it will be a kind of natural stimulant for erythropoiesis. Over that, these are all the oral agents, so the convenience will be better. These factors will also decrease the inflammation level in our body. So what happens in those CKD patients who are having inflammation? Bone marrow will be suppressed over longer time. So in that case, just supplementing with iron or erythropoietin will not help in stimulating that bone marrow because of the counteracting inflammation part. So we have to reduce inflammation as well. So these novel agents will help in reducing inflammation so that bone marrow will again start functioning properly. So these are some advantages of these new agents, but still they are not the first line agents as mentioned because the long term safety and the efficacy are not yet known. So what are some key principles? Do not use combination therapy because both will act almost in a similar mechanism and the hemoglobin threshold or the target will remain same as ESA therapy. And once you start on these therapies, if you don't observe any advantages over 3 to 4 months, stop it and do not continue this particular treatment. But remember, in some populations, you have to be very, very careful. For example, this hypoxia inducible factor will also lead to excessive production of VEGF, vascular endothelial growth factor. This might lead to neovascularization in retina. Also, it can stimulate cancerous cells. That's why any individual who is having active cancer or history of cancer, we should avoid this particular agent. And just like ESS, this particular agent will also have the risk of major adverse cardiovascular events. And its efficacy in treating anemia in post-kidney transplant individual is not yet known. So these are some factors we have to know about these newer molecules. Next and final chapter is about red blood cell transfusions. So remember few important things. Whenever you are using RBC transfusions, carefully we have to weigh the risks and benefits. And the decision of transfusing blood should depend on the signs and symptoms, not upon the hemoglobin threshold. So when the benefits will be more compared to the harm. Suppose you have tried with supplementation, erythropoiesis stimulating agents, even then if it is found to be ineffective in correcting anemia, in that case we have to think of bone marrow failure. So no more it will be able to produce, we have to supplement from outside in the form of RBC transfusions. Then in some individuals, suppose these agents are harmful, for example active malignancies or high risk of cardiovascular events. So in that case as well, we can go ahead with transfusion. Then suppose in some case rapid correction is required to stabilize the individual, for example acute hemorrhage or unstable cardiovascular disease. In that case also we have to rapidly correct the anemia. And in preoperative hemoglobin correction, rapidly we need to correct it before the individual undergoes the planned procedure. So in that case as well, we can utilize blood transfusion. But always remember a risk of allo sensitization. In patients who are eligible for organ transplantation, avoid transfusing RBCs whenever possible so that we can minimize the risk of developing antibodies, donor-specific antibodies, which can significantly delay or prevent transplant in future. That's why if you get a case of young CKD and if you know that probably this individual might get benefit from kidney transplant, so in that case try to avoid blood transfusions to prevent allo immunization. So in summary of this particular chapter from KDIGO 2026 Anemia in CKD, we can say that There are some newer terminologies like systemic iron deficiency and iron restricted erythropoiesis for better physiological clarity. Then what about iron therapy? Suppose the individual is on hemodialysis, treat it aggressively. For example, even if the ferritin is less than 500 or saturation near 30%. And in this case, always prefer IV route rather than oral, and it should be a proactive approach, that is monthly maintenance therapy. Suppose the individual is not on dialysis, then there are some different numericals which we have to remember, and in that case both oral and IV therapy will be equally effective. Then chapter 3 focused mainly upon erythropoiesis stimulating agents and HIF PHIs. So even now we have to suggest ESA over these newer molecules as initial therapy, and whenever we are using, keep the target hemoglobin of less than 11.5. Coming to blood transfusion, mainly RBCs transfusion. In potential transplant candidates, try to avoid this to prevent a low sensitization, and the decision of blood transfusion should be decided based on signs and symptoms, not upon the hemoglobin levels. Thank you so much. So this was the overall elaborate discussion about the recent update on management of anemia in CKD by KDIGO 2026. Hope you find it helpful. If so, please share it among your friends, and don't forget to subscribe to the channel for more such informative videos. Thank you.